Welcome to the audio digest of the American Journal of Psychiatry. I'm Dr. Susan Schultz with highlights for September 2010. This month we've got 2 articles on psychiatric manifestations of paraneoplastic disorders. 2 others are about developmental aspects of schizophrenia, prenatal and neonatal brain structure in children at high risk for schizophrenia, and prediction of psychosis by negative and disorganized symptoms in adolescents and young adults. William Carpenter has written an editorial that relates these early symptoms to current concepts in psychiatric diagnosis. We'll conclude with an article about how histamine-related genes influence the effects of food additives in children's ADHD symptoms. This article has been selected as meriting CME for readers who subscribe to the AJP CME course program. Each month, brief companion exams are created for 3 of the most influential articles from the issue. By reading the articles and completing the online exam, individuals can earn up to 1 AMA PRA Category 1 credit per article. This activity is sponsored by the American Psychiatric Association. To subscribe, click on the CME link at our homepage, ajp.psychiatryonline.org. Of course, there's even more in the full September issue. Authors from the Veterans Administration have identified features linked to anger and aggressiveness in veterans of the Iraq and Afghanistan wars. And 2 epidemiological studies show that air pollution and asthma are related to suicide rates. We'll start with the Clinical Case Conference by V.J. Middle and colleagues. It's about a pineal gland tumor in an adolescent with prodromal psychotic symptoms. He's called David, and he was referred at age 17 to a clinical research program for assessment and prevention of prodromal states. He had severe obsessive-compulsive behaviors and subthreshold symptoms of psychosis. He'd been an A student in elementary school and was accepted into a program for gifted students, but a marked behavioral decline began at the onset of puberty. His grades dropped to the D range by the time he was in 9th grade. He also showed a decline in verbal expression and several unusual behaviors, repeatedly checking the time, insisting that the bed covers had to be folded a certain way, and consuming excessive amounts of salty foods. As the year progressed, David shifted from being preoccupied with salty foods to drinking excessive amounts of water. This was diagnosed as psychogenic polydipsia. He was referred for psychiatric treatment, but neither psychotherapy nor pharmacotherapy decreased his symptoms. In the 11th grade, David began having unusual thought content. He endorsed a belief in mind reading, and he said he sometimes felt like he was at the center of people's attention. He also reported that he'd repeatedly heard clapping and hissing sounds, but was unable to find their source. An MRI scan without contrast was done as part of a neurologic consultation, and it showed no irregularities. Neurological dysfunction was suspected because David also had behaviors that weren't typical prodromal symptoms of psychosis. He had stereotyped and idiosyncratic hand gestures and had adopted a bizarre series of handshakes. He'd begun to wander away from home and get lost. He also lost orientation to time and date, and he began injuring himself. Eventually, David began to express overtly psychotic symptoms, including thought withdrawal and both olfactory and auditory hallucinations. Another MRI was performed with and without contrast. This time it showed a soft tissue mass in the region of the dorsal midbrain and pineal cistern. A biopsy indicated a tumor 29 millimeters at the widest point. The scan also showed a small left-sided basal ganglia stroke. The tumor had also resulted in hydrocephalus with distension of the third and lateral ventricles. A shunt was immediately put in place to treat edema, and then chemotherapy was begun. At the end of treatment, the tumor size had decreased to less than 4 millimeters. However, the sequelae of the tumor included panhypopituitarism and diabetes insipidus. David also reported that he had peripheral vision loss, and the motor functioning on the right side of his body was still impaired. His behavior improved, but he still had mild depressed mood and some of the unusual behaviors. His psychotic symptoms decreased to the mild range. David's polydipsia abated, likely as a result of treatment for the diabetes insipidus. The pineal gland is located at the posterior extent of the third ventricle and extends over the tectal plate of the midbrain. Through the production of melatonin and subsequent modulation of sex hormones, the gland is a key structure in sexual development and the onset of puberty. Tumors in this region are rare and account for about 1% of all brain tumors. They occur most often in children and young adults. The most common types are germ cell tumors, which arise from the embryonic remnants of germ cells. They're malignant and invasive and may be life-threatening. Given the importance of the pineal gland in pubertal development and the timing of David's symptoms, this case may provide important clues about the pathophysiology of psychotic disorders and their typical onset in adolescence. Several lines of evidence suggest a possible relationship between pineal gland abnormalities and symptoms of thought disorder. Pineal gland irregularities, such as calcification, have been observed in schizophrenia, and they may be related to abnormal nocturnal secretion of melatonin in patients with schizophrenia. It's also possible that David's stroke in the basal ganglia contributed to his obsessive-compulsive symptoms. Disorders that involve the basal ganglia, such as Huntington's disease, can present with both psychotic and obsessive-compulsive symptoms. Structural and functional neuroimaging studies have shown abnormalities of the basal ganglia and related brain circuitry in obsessive-compulsive disorder. And what appeared to be David's compulsive water drinking actually reflected diabetes insipidus, which was likely related to his subcortical brain pathology. For a review of the psychiatric manifestations of paraneoplastic disorders, we turn to Matthew Kaiser and colleagues. They note that the prevalence of paraneoplastic syndromes depends on the type of cancer. It ranges from below 1% in breast and ovarian cancer to 20% in thymomas. Limbic encephalitis is one of the best understood causes. The classic syndrome evolves over days to weeks and includes psychiatric changes such as irritability, depression, hallucinations, personality disturbances, and cognitive changes. Patients may also have sleep disturbances, confusion, and seizures. The CSF often shows a mild lymphocytic pleocytosis. The MRI may demonstrate unilateral or bilateral medial temporal lobe hyperintensities on FLAIR and T2-weighted images, with progressive loss of hippocampal gyrus volume upon repeat imaging. Evidence now points to immunologic mechanisms. In many cases, a specific autoantibody occurs exclusively with a given clinical syndrome and often with a specific cancer type. The antibodies can be categorized on the basis of the cellular locations of the antigens they recognize. One group of antibodies is directed against intracellular neuronal antigens. The most common known paraneoplastic neurologic syndrome is associated with anti-Hu antibodies. The encephalitis usually manifests as classic limbic encephalomyelitis occurring with small cell lung cancer. Limbic encephalomyelitis entails a wide spectrum of neurologic dysfunction, including sensory neuropathy, motor neuron abnormalities, and cerebellar ataxia. These patients often seek help in their 50s or 60s with a long history of smoking and complaints of painful sensory neuropathy, recent confusion, and amnesia. Overall, they fare poorly, with a median survival of about 1 year. A decade ago, an autoantibody syndrome was associated with testicular germ cell tumors, and paraneoplastic limbic encephalitis was described. Antibodies recognize the onconeuronal antigen MA2. Isolated anti-MA2 antibodies are usually seen in young men with disturbances specific to the central nervous system. Most often, limbic encephalitis, along with hypothalamic and/or brainstem encephalitis. Severe short-term memory deficits are the most common feature, and other neurologic deficits are frequent. One interesting relationship is the apparent connection between anti-MA2 antibodies and sleep dysregulation of hypothalamic origin. Patients with isolated anti-MA2 antibodies may respond well to treatment of the tumor and to immunotherapy. Anti-CRMP5 and anti-CV2 antibodies are most common in patients with small cell cancer, but also occur in thymoma and other tumors. Patients have a wide spectrum of neurological symptoms, most notably involuntary movements, often involving the face. Optic neuropathy and abnormalities of olfaction and taste have unusually high frequencies. Cognitive deficits in limbic encephalitis are also common. Outcomes are unclear. In one study, the involuntary movements improved with tumor treatment, immunotherapy, and antipsychotics, and about half the patients survived 4 to 42 months after the onset of chorea. Many patients have psychiatric changes and chorea, so it's important to differentiate this disorder from Huntington's or Wilson's disease. Another group of antigens are located on the cell's surface. Antibodies against voltage-gated potassium channels are usually not associated with paraneoplastic disorders, but about 20% of the time they occur with small cell lung cancer or thymoma. This type of limbic encephalitis typically affects middle-aged or older patients. They develop severe verbal and visual memory deficits and confusion or disorientation. Seizures are common, but this syndrome rarely involves CSF pleocytosis. Psychiatric disturbances are diffuse, but behavioral changes are frequent and often include apathy and irritability. They may occur with signs of autonomic dysfunction, such as excess sweating and salivation. About 80% of patients with limbic encephalitis caused by antibodies against voltage-gated potassium channels improve after prompt treatment with high-dose steroids, intravenous immunoglobulins, or plasma exchange. Neuropsychological improvements are less robust, and the majority of patients still have some short-term memory deficits. Perhaps the most intriguing disorder with regard to psychiatric symptoms is the autoantibody syndrome involving the NMDA-type glutamate receptor. The antibody was identified only a few years ago, but about 200 patients have now been described. Many of them were misdiagnosed with acute psychosis, malingering, or drug abuse. Typically, the patients are young women or children with prominent psychiatric symptoms, including anxiety, agitation, bizarre behavior, delusional or paranoid thoughts, and visual or auditory hallucinations. The vast majority experience a prodrome-like illness after which their neurologic status deteriorates over several weeks. It progresses to a catatonic-like state with dyskinesias, autonomic instability, and hypoventilation, requiring intubation in some patients. CSF findings are typical of encephalitis, but MRI findings are unreliable. Studies now indicate that approximately half of the patients don't have identifiable tumors, and this percentage is higher in children. In the patients with neoplasms, nearly all of them develop psychiatric or neurological symptoms before the tumor diagnosis. Surprisingly, these patients often recover with treatment. A recently discovered paraneoplastic disorder with limbic encephalitis is characterized by antibodies against subunits of the AMPA-type glutamate receptor. 10 patients have been described. 9 were women, and the median age was 60. Almost all of them had subacute memory loss and confusion. The other most common symptom was agitation or aggressive behavior. 7 had associated tumors of the breast or lung or thymoma. All of the patients with identified tumors received cancer treatment, and 9 received immunotherapy. All the patients receiving immunotherapy responded well. One of the most striking features of this condition is the tendency to relapse despite treatment, even in the absence of a tumor. It's likely that there are other paraneoplastic disorders, and several syndromes have been proposed. Now we'll look at neurodevelopment and schizophrenia. There's evidence that low-grade psychotic experiences may precede clinical psychotic states by many years. Maria de Gracia Dominguez and colleagues selected a population sample of young people ages 14 to 24 and interviewed them at baseline and at multiple points over the next 10 years. Early expression of negative or disorganized symptoms predicted the onset of psychotic experiences and subsequent clinical psychosis. The baseline sample was drawn from population registry offices in Germany to randomly select individuals 14 to 24 years old. The final survey occurred 7 to 10 years from baseline. The primary goal was to examine developmental aspects of psychopathology, and so respondents 14 or 15 years old were sampled at twice the rate of persons 16 to 21, and the oldest group was sampled at half the rate. More than 3,000 participants were included in the sample. Interviews were conducted with the Munich Composite International Diagnostic Interview. Clinical psychologists used the lifetime version at baseline, and at the follow-up assessments they used the interval version, which covers the period from the previous interview. This information was used to determine the presence of two psychopathological clusters, one for negative and disorganized symptoms, and one for positive psychotic symptoms. In factor analytical studies of chronic psychotic patients, negative and disorganized clusters consistently load on separate domains. However, meta-analysis indicates that they don't have distinct associations with neurocognitive alterations, and so they were combined in this study. At baseline and the final assessment, the items used to represent the combined cluster were indifference and thought incoherence or illogicality. At the second survey, 5 additional items were available: flat affect, slow speech, slow movement, poverty of speech, and avolition. Classic psychotic symptoms were assessed in the 2 follow-up evaluations. The surveys included information about sociodemographic characteristics, environmental risk factors, and antipsychotic medication. The respondents were also asked whether they had seen a doctor for delusions or hallucinations and whether they had sought help from other mental health professionals. Other questions focused on the effects of psychotic experiences on work, recreation, and social functioning. Both negative and disorganized symptoms and positive symptoms had 5-year cumulative prevalence rates of about 12%. The combination of both clusters occurred more often than predicted by chance. The cluster of negative and disorganized symptoms was significantly related to younger age, male sex, single marital status, and low educational level. The positive cluster was associated with low education level, cannabis exposure, urbanicity, and self-reported trauma. The combination of both clusters was significantly associated with all variables except gender. Across the entire study, the negative and disorganized cluster was significantly related to the positive cluster. Persistence of the negative and disorganized cluster was predictive of onset of the positive cluster. However, the prospective association between the positive cluster and onset of the negative cluster was neither large nor significant. The co-occurrence of positive and negative symptoms was predictive of clinical outcomes in terms of both secondary functional impairment and help-seeking behavior. So negative and disorganized symptoms predicted psychotic experiences, but not vice versa. This finding is consistent with the view that negative and disorganized symptoms stem from altered brain development due to genetic risk for schizophrenia, and that these alterations lead to neurotransmitter dysregulation and positive psychotic symptoms, especially if combined with environmental exposures. This article touches on some of the issues that interest William Carpenter, and he's written an editorial about them, conceptualizing schizophrenia through attenuated symptoms in the population. First, he considers separate domains of pathology. Studies support disorganized thought and behavior as separable from both negative symptoms and positive psychotic symptoms. Kreplin considered avolition and dissociative pathology as the two clinical maladies that can co-occur and present as dementia praecox. Avolition is a component of negative symptoms. Disorganization includes the split within thought and between thought, affect, and behavior. When avolition and disorganization are combined, the prognosis is worse and the probability of schizophrenia is increased. The separation of these two pathologies in some cases of schizophrenia may be partly due to treatment, since antipsychotic drugs don't have efficacy for negative symptoms. Also, disorganization can lead to secondary negative symptoms, which further confound the relationship. The study by Dominguez and colleagues demonstrates in a population-based cohort that negative symptoms often precede the onset of psychosis. It also shows a differential relationship with risk and prognostic variables. Earlier onset, being male, and being single and having less education were associated with negative and disorganized pathology. The authors suggest that this aspect of pathology is developmental and that it represents a genetic liability. This seems likely since some genes associated with schizophrenia are expressed only during brain development, but a number of environmental risk factors also occur early. Prenatal stressors include infection and complications at delivery. Neurodevelopmental etiological pathways surely include genes, epigenetic alterations, and environmental insults directly affecting brain development. The study also showed a later onset of positive psychotic symptoms and their association with environmental risk factors that developed later. These suggest a different causal pathway. The low education level probably reflects impaired cognition and motivation, but urbanicity, cannabis, and trauma could contribute to the causal pathways. These data raise the possibility that neurodevelopmental pathology is manifest in negative and disorganized symptoms, but also creates a vulnerability for positive psychosis in the context of later environmental insults. The study is especially timely as it relates to two areas of potential innovation in the DSM-5 chapter on psychosis. It indicates that positive psychotic symptoms are a separate domain from negative and disorganized symptoms in young people with attenuated symptoms. This reinforces the view that schizophrenia and other psychotic disorders are syndromes rather than disease entities, and that individuals in the same class have substantial differences in psychopathology. This calls for deconstruction of the syndrome into component parts, something that has been advocated for DSM-5. There are plans to field test a set of dimensions representing numerous clinical phenomena. The second issue is very controversial. There's substantial evidence that attenuated psychotic symptoms can be used to identify persons at increased risk for developing a full psychotic syndrome. The data in this study add further support. They suggest that combining negative and disorganized symptoms with attenuated psychotic symptoms increases the identification of clinical relevance. It's been suggested that a diagnostic class be established for help-seeking persons who manifest attenuated psychotic symptoms, since early treatment of schizophrenia is most effective. This proposal raises several concerns. The extension of psychiatric diagnosis into non-ill populations, the potential for excessive medication use, possible stigma, and the level of expertise required to apply the criteria reliably. However, the criteria proposed for DSM-5 require that the person not have another DSM disorder and that distress, disability, and dysfunction be present. Field trials will determine the reliability of the diagnosis in ordinary clinical settings. It's also been argued that antipsychotic drugs are already used excessively in this age group, and organizing awareness of this classification might decrease rather than increase the use of these drugs before psychosis is manifest. And stigma may not be related just to diagnosis. It may also be associated with abnormal behaviors and with problems in friendships and role performance. John Gilmore and colleagues also looked for indications of schizophrenia before the onset of clinical symptoms. They looked even further back at prenatal and neonatal brain structure and white matter maturation in children at high risk for schizophrenia. They measured prenatal head circumference and lateral ventricle width by means of ultrasound and brain volumes of infants by means of MRI. To examine the maturation of white matter, diffusion tensor imaging was used to measure neonatal diffusion properties of the genu and splenium of the corpus callosum and corticospinal tracts. Children of mothers with schizophrenia or schizoaffective disorder were matched with offspring of pregnant women without psychiatric illness. 2 ultrasound scans were obtained. 11 matched pairs of high-risk and comparison offspring received an ultrasound in the 2nd trimester, and 16 pairs got one in the 3rd trimester. At both times, there was no significant difference between the groups in either lateral ventricle width or head circumference. MRI imaging of the infants was done approximately 43 weeks after the mother's last menstrual period. Scans were available for 26 matched pairs of high-risk and comparison infants. 12 were male and 14 were female in each group. Most of the high-risk infants had prenatal exposure to an antipsychotic. They were also more likely to have been exposed to antidepressants and cigarette smoking during pregnancy. There were no significant overall differences between the high-risk and comparison groups in the intracranial, lateral ventricle, and cerebellum volumes or in any tissue volume. However, among the male infants, the high-risk group had significantly larger intracranial volumes than the comparison group. They also had significantly larger total gray matter, total CSF, cortical gray matter, and lateral ventricle volumes. But these differences were not significant when adjusted for intracranial volume. There were no group differences for any tissue volume in the female infants. There were also no significant differences between infants who were exposed to cigarette smoking and those who weren't. Diffusion tensor imaging scans were obtained for 19 pairs of infants, 6 male and 13 female per group. There were no differences between the high-risk and comparison groups in fractional anisotropy or mean diffusivity for any region in the genu and splenium of the corpus callosum or in the left and right corticospinal tracts. Children were also the focus of a genetic study on attention deficit hyperactivity disorder. Jim Stevenson and colleagues report on the role of histamine degradation gene polymorphisms in moderating the effects of food additives on children's ADHD symptoms. Genetic factors account for some of the differences in symptoms between individuals, and a number of genes involved in this effect have been identified. They implicate the dopamine, serotonin, and noradrenergic systems, but these effects account for only a small portion of the genetic risk suggested by quantitative gene analysis. Variations in ADHD symptoms have also been attributed to environmental effects. Artificial food additives have been postulated to place children at risk for ADHD. There's less clear evidence for the adverse effect of such additives on behavior in children in the general population. Stevenson and colleagues chose the histamine neurotransmitter system for further genetic testing. The activity of central histamine H3 receptors has been shown to affect inhibition learning, to increase hyperactivity in mouse models, and to promote dopamine release in the frontal cortex. There's evidence that histamine might mediate the effects of artificial food colors on ADHD symptoms. The present study examined whether the effect of food additives on ADHD is moderated by differences in polymorphisms in a gene involved in histamine degradation, HNMT, for histamine N-methyltransferase. Previously implicated genes related to catecholamine neurotransmission were also included. The study included children in 2 age groups. A community sample of 3-year-old children was drawn from preschools and other common preschool settings. A sample of 8 and 9-year-old children was obtained from city schools. There were approximately 150 in each group. The study was a randomized, double-blind, placebo-controlled food challenge that included a within-subject crossover. There were 2 active mixes of artificial food colorings, Mix A and Mix B. After a week of the child's normal diet, the food colors and sodium benzoate were excluded from the diet over 6 weeks. Over the following 6 weeks, the child was given 3 challenge drinks, Mix A, Mix B, and placebo. Each of these was consumed for 1 week, and the conditions were separated by a week of placebo washout. Hyperactivity was measured with a composite rating based on observations of parents and teachers. The composite for the 8 and 9-year-old children also included the Conners Continuous Performance Test. The study was designed to show differences between the active and placebo periods. The effect of Mix A was compared to the effect of placebo, and the effect of Mix B was compared to placebo. Cheek swabs were collected from the children for the genotype analysis. At baseline, 2 of the polymorphisms tested were related to the global hyperactivity score in the 3-year-old children. One of the polymorphisms was in the gene related to histamine degradation, HNMT, and the other was in the dopamine D4 receptor gene. There were no effects at baseline in the older children. Stevenson and colleagues previously showed that there were significant effects of challenge type on the global hyperactivity score. In this study, they looked at whether these effects differed between the 2 genotypes for each gene. For one of the HNMT polymorphisms, there was a significant effect of Mix A relative to placebo in the children missing the allele of interest. This was observed in both the younger and older groups. For the 8 and 9-year-old children, there were also significant interactions between genotype and challenge type for the other tested polymorphism in the HNMT gene. For Mix B, the effects on the 3-year-old children were the same regardless of the HNMT polymorphisms. Among the older children, interactions of Mix B with the 2 HNMT polymorphisms were found. A significant effect was also observed for children with the short-form allele of the dopamine D1 transporter gene. This study opens up research on ADHD to neurotransmitters besides catecholamines. It also verifies the value of molecular studies of genes whose involvement is postulated rather than identified in a whole genome search. Since a food additive challenge can cause histamine release, and polymorphisms in the HNMT gene impair histamine clearance, it's plausible that these variations would affect the reaction to food additives. Moreover, it's become apparent that 2 widely used treatments for ADHD, methylphenidate and atomoxetine, may have effects mediated via the histamine system. This wraps up our audio highlights of the September issue of the American Journal of Psychiatry. Please visit our website, ajp.psychiatryonline.org, for the complete versions of these and other articles, including author affiliations and financial disclosures. We also welcome comments about our audio digest. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Next month, our audio will highlight antipsychotic treatment of delirium in severely ill children, the effects of antidepressant step therapy on medical spending, suicide in women with borderline personality disorder and PTSD, and the effects of hypertension and increased body mass index on cognition in schizophrenia. We hope that you'll join us. Thank you.